Hi, everyone. My name is Anne-Marie Hayes. I'm a research associate on the Joplin campus of KCU. Thanks for joining us today for our journal club presentation. Today, I'll be introducing our speaker, student Dr. Carter. Student Dr. Michael Carter received their Bachelors of Science Degree in Public Health, concentrating in Epidemiology and Immunology, and are now a second-year DO student at Kansas City University. Their previous research consists of working in an infectious disease laboratory focusing on vaccine development to prevent cholera outbreaks in developing areas. After starting medical school, they started working at Children's Mercy Research Institute in a pediatric clinical research laboratory, focusing on cognitive development and obesity prevention in children. Their current specialty interests are general surgery and reconstructive plastic surgery. So with that, the floor is yours, student Dr. Carter.
Thank you. So as Anne-Marie said, my name is Michael Cole Carter, and the topic of interest that I'll be presenting today is when and how should we revascularize patients with atherosclerotic renal artery stenosis. And this specific topic was done by Dr. Prince, and he's really well known throughout the cardiology world. He currently works at a clinic in Houston, and he has many publications talking about revascularization. And we'll get more into what exactly revascularization is in the next few slides. So a definition of what renal artery stenosis actually is that it's a narrowing of one or both renal arteries. And this really provides a concern for secondary or refractory hypertension. Secondary hypertension being it's not due to diet, it's mainly due to another disease, and refractory hypertension is uncontrolled hypertension despite using antihypertensives. The main causes of renal artery stenosis is atherosclerotic disease, proposing about 90% of the cases, with fibromuscular dysplasia in young women composing about 10%. Atherosclerotic disease is cholesterol plaques that typically deposit in the proximal 1/3 portion of the renal artery. And then the fibromuscular dysplasia in young women, it's pretty rare and typically affects younger women. And that's in the distal 2/3 portion of your renal artery. So the prevalence of atherosclerotic renal artery stenosis, and instead of saying the whole name, I'm just going to say RAAS from here on out. It's really largely dependent on the population screened. So of all hypertensive patients, RAAS patients compose about 5% of that. And then once you start incorporating more kidney dysfunction, the amount of RAAS patients compose a large population. So in dialysis, 15%, elderlies with CKD compose about 25%. And then moving on to coronary artery disease, this is when it jumps up quite a bit to 30%. And then peripheral artery disease having about 40% of RAAS patients composing that population. So clinical manifestations that we're primarily concerned about with renal artery stenosis, the first one being secondary or refractory hypertension. We kind of briefly already touched on that one. So moving on to cardiac destabilization syndromes, and then ischemic nephropathy. And over the course of the next few slides, I'm going to break down each one of these and talk about the mechanism of action of each one. So renal activation of hypertension. So under when a normal kidney gets adequate perfusion, it maintains adequate blood pressure. But under the circumstance that the renal artery gets kind of a buildup of plaque in that proximal 1/3 portion, it starts getting decreased blood flow, and the kidney's immediate response to that is to increase blood pressure, given that it's the main controller of blood pressure. And it does this by increasing sodium reabsorption and decreasing urinary excretion of sodium. By doing this, it's going to amp up blood pressure, and it's going to put a lot of stress on the kidneys and a lot of stress on the heart. So as you can see, prolonged cholesterol deposit and renal artery stenosis is going to have some detrimental effects to your health. And how it actually amps up blood pressure, this gets a little complicated, but it's the RAAS mechanism, so your renin-angiotensin activating system. And how it does this is that whenever your renal artery gets stenosed by atherosclerotic plaques, it starts narrowing. And what happens is your body senses and stimulates norepinephrine to kind of increase your blood pressure, and angiotensinogen is secreted by your liver as well as renin being secreted by your kidneys. And they're secreted by specialized cells in your kidneys called juxtaglomerular cells. And angiotensinogen comes and binds onto that renin and is then converted to angiotensin 1. Angiotensin 1 is then converted to angiotensin 2 by angiotensin converting enzyme, or as we call it, ACE. And then angiotensin 2 has two different primary ways of increasing blood pressure. One, it can stimulate your adrenal gland to produce aldosterone. Aldosterone works in the collecting duct of your kidney, which enhances sodium chloride reabsorption, but also causes vasoconstriction. And both of these work together to increase blood pressure. Angiotensin 2 also works on your posterior pituitary, stimulating ADH release. This also works on your kidney to increase water reabsorption and thirst. So both of these pathways together really amp up that blood pressure from normal. Moving on to cardiac destabilization syndromes. What these syndromes are basically syndromes that destabilize your heart. And the main syndromes that we're worried about are congestive heart failure and acute coronary syndrome patients, because RAAS has a high clinical manifestation in these patients. Whenever a patient presents with CHF or ACS, you really want to make sure you're paying attention to whether or not they're coming in with flash pulmonary edema, or if they've had a history of it or emergent episodes of this, where their lungs fill with fluid. And what happens is the patients kind of feel like they're suffocating and they can't breathe, there's shortness of breath. And this is a huge issue. So if you do have a cardiac destabilization syndrome patient like ACS with flash pulmonary edema, it's going to prompt a clinician or investigator to investigate the potential of having atherosclerotic renal artery stenosis. So it's a good identifier for clinicians. And lastly, ischemic nephropathy. This is basically an overall decrease in renal perfusion with blood due to atherosclerosis. This is going to decrease your GFR, which is glomerular filtration rate, and renal mass, as well as have an increase in parenchymal fibrosis. Both of these combined really stress out the kidney and can put you into potential kidney failure and really stress out the heart as well, making it work overtime. When a clinician checks a urinalysis, you'll see proteinuria, which is basically the kidney being unable to filter properly. And then lastly, treatment for this is going to be revascularization, so a surgical technique to promote proper renal function again. And revascularization is the main topic of this presentation, so I kind of want to give you the actual definition in a little bit when we get to it. So diagnosis and treatment. Renal Doppler ultrasound is the gold standard with 95% specificity and 90% specificity. And CTA and MRA follow. So renal Doppler ultrasound is the gold standard just because it's so easy to access, it's very convenient, it's cheap, and it can determine whether someone has renal artery stenosis very quickly, while CTA and MRA follow, but they have a risk of allergies, they're expensive, and they're very inconvenient and take some time. The treatment for renal artery stenosis are ACE inhibitors and ARBs. So these are antihypertensive medications, and these two medications specifically are the primary treatment because they block specific pathways on that RAAS activation that we just went over. If you do take these medications and your blood pressure is still uncontrolled with renal artery stenosis, you then want to move to revascularization. And what revascularization is, it's a surgical technique where you have to open up your renal artery and you try to get increased renal perfusion. So looking down at this diagram, in the groin of the patient, the surgeon will come in through the femoral artery, work its way up into the abdomen through the abdominal aorta, and then eventually find its way to the renal artery. And once it gets to the renal artery, it can see the stenosed plaque buildup. It can insert a stent and increase the diameter of the renal artery so it can get adequate blood perfusion. This will hopefully succeed and there won't be any complications, and it'll eventually lower blood pressure for the patient. So this has been the huge topic of debate is, yes, there's medical treatment with drugs, and yes, there's revascularization, but it's what specific patients fall into the category of whether or not you need to use revascularization or whether you want to just use medical therapy alone. And what it was found, so before we kind of jump into this diagram, it was found that all clinicians really need to find the severity of atherosclerotic renal artery stenosis being greater than 70%. And how they did that was they utilized something called the resting translesional mean gradient, and this detected the pressure within the renal artery, and they found that if it was greater than 10 milligrams per mercury, then they had severe renal artery stenosis. So these patients would then qualify for revascularization, but if they didn't have greater than 70% stenosis, then you would want to try medical therapy alone. So going to the top, they're giving different scenarios for patients that would qualify for revascularization. So the first one we've talked about a little bit, cardiac disturbance syndromes like flash pulmonary edema, unstable angina, or ACS, with hypertension and moderate renal artery stenosis, with the resting translesional mean gradient of greater than 10 milligrams per mercury. The next scenario, CKD stage 4 with bilateral moderate renal artery stenosis with a resting translesional mean gradient of greater than 10 with kidney atrophy with a kidney size of about 7 centimeters. The third scenario of CKD stage 4 and global renal ischemia, so lack of adequate perfusion to the kidney without another explanation. And then lastly, resistant hypertension and bilateral or solitary renal artery stenosis. And this resistant hypertension, so as we talked about, you want to primarily use medical therapy with drugs to start with. If those fail and you are using 3 antihypertensive agents, one being a diuretic agent, and you still are having high blood pressure, then you want to proceed with revascularization. So when not to treat with revascularization. So asymptomatic patients, obviously you don't want to do surgery and do an invasive procedure on asymptomatic patients. You can start off with an ACE or an ARB or a combination of both. See if those decrease the blood pressure and continue from there. Patients with uncontrolled blood pressure, not on maximal guideline-directed medical therapy. So again, being on at least 3 antihypertensive drugs, one being a diuretic. And if you still have uncontrolled blood pressure after that, then proceed with revascularization. Ischemic nephropathy with CKD 3 and 4 patients. So it was shown that ischemic nephropathy alone and CKD patients alone can have revascularization, but the combination has mixed results. So you want to be careful about proceeding with revascularization with ischemic nephropathy patients with CKD. And then hemodialysis patients that have been on hemodialysis for greater than 3 months. And then lastly, I want to just reiterate that you want to use imaging modalities to determine the severity of atherosclerotic renal artery stenosis, just to determine whether the patient is actually eligible for the revascularization surgery. So what this article really did was it incorporated a lot of different articles to support that it did drop blood pressure in patients that were eligible for revascularization. So in the top bullet point, this was an article looking at unsuccessful balloon angioplasty. And balloon angioplasty, it's a great technique, sometimes used over stenting, which in balloon angioplasty, you basically do the same route as a renal stent, but instead of placing a stent, you basically just dilate the renal artery with a balloon. This does have a lower success rate, but it does have a lower risk of thromboembolus. Since these were unsuccessful, the surgeon then proceeded with stenting. So 227 patients with renal artery stenosis were in the study, and they wanted to achieve 50% stenosis or less. Among these 227 patients, 182 patients were successful in reducing their systolic blood pressure from 168 to 149, and then diastolic reduction from 82 to 77. So as you can see, renal stenting through revascularization is a very successful technique if you qualify and you have severe stenosis. And then the second study that was used in support was Herculink Elite Renal Stent to treat renal artery stenosis, and this looked at 202 patients. And it was found to have a significant systolic reduction with uncontrolled hypertension. The reason the study worked really well is because the mean medications that these patients were on for hypertension was 3.4, so over the guideline-directed medical therapies. So they were really trying to control their blood pressure. It would be a limitation if it was under 3. The clinical success rate of dropping their blood pressure was 98%, and a relief from major adverse events was 94.8%. And these major adverse events were hospitalizations and blood pressure crises. So these randomized trials following this is looking at guideline-directed medical therapy, so hypertensive medications versus utilizing revascularization. So the first study that was used in support of this article was population with greater than 50% stenosis with a creatine clearance of less than 80 mils per minute. So this is basically saying your renal arteries are very severely messed up. Studies looked at the guideline-directed medical therapy versus guideline-directed medical therapy plus revascularization, and the renal artery stenting had no effect on progression of CKD. Unfortunately, the limitation in this study is due to the participant severity of the RAAS. So they didn't meet that. So they did have severe stenosis, but they didn't have severe stenosis greater than 70%. And that's the criteria that you need to use when considering revascularizing someone. So again, it really reemphasizes that you must meet this criteria to see optimal results with your patients. And then the second study was comparing GDMT with revascularization alone. And they found that there was no benefit of revascularization over guideline-directed medical therapy or using antihypertensives. And there were two major limitations to this study, one being due to the lack of guideline-directed medical therapy. So as you can see, the mean use was 2.7, so under the max dose of antihypertensive medications that they want us to be at the threshold for, which is 3. And also that 60% of participants had less than 70% atherosclerotic renal artery stenosis. So that was another criteria that wasn't met in this study. So again, re-emphasizing that you must meet these guidelines to have proper results. So kind of reverting back to blood pressure outcomes, we hit blood pressure outcomes, cardiac destabilization syndromes, and ischemic nephropathy. And I kind of want to return to those to show overall outcomes of revascularization. So for blood pressure outcomes in a 4-year follow-up study, following revascularization on patients with uncontrolled hypertension, this was dealing with about 1,058 patients. And among the 1,058 patients, it saw a decrease in systolic blood pressure from 168 to 147, diastolic pressure from 84 to 78, and there was a statistically significant decrease in the amount of hypertensives that were utilized to control their blood pressure. So as you can see, revascularization dramatically helps the patients with renal artery stenosis in controlling their symptoms. For cardiac destabilization outcomes, there was a longitudinal follow-up study with Cleveland Clinic in CHF patients. 207 patients had decompensating heart failure, but they actually correctly identified 40 patients that had severe renal artery stenosis, which is greater than 70%. And the 40 that received that revascularization had significant decrease in their CHF symptoms, decrease in hospitalizations, reduced pulmonary edema, and a much better response to their blood pressure medications and heart medications. And lastly, ischemic nephropathy, like I've kind of touched on a little bit before, it's really hard to determine the outcomes due to comorbidities. So atherosclerotic renal artery stenosis isn't the only thing that contributes to ischemic nephropathy. You have many other diseases that can contribute to it. So the results are kind of mixed. So moving down, mixed reports of benefits of revascularization. There were some surgeons who did revascularization and it showed that there were some favorable outcomes, with other surgeons saying that there were worse outcomes. So worse control of blood pressure and adverse effects. I mean, especially the older patients having to undergo surgery. And then further randomized trials are needed for exploration of whether ischemic nephropathy qualifies for revascularization. And lastly, the main thing we are concerned about when revascularizing a patient is restenosis after ablating the renal artery. And it was found that arterial diameters at time of revascularization inversely correlates with restenosis. And what this means is that the larger the diameter was at the beginning, the less likely chance that it had of closing again. So there was a study done with 363 patient samples that checked for restenosis after revascularization, and only 102 did a follow-up, but it was found that 36%, so a very high restenosis rate with less than 4 millimeters arterial diameter. This dropped by half with 16% restenosis with a 4.5 to 6 millimeter arterial diameter. And then again, it dropped dramatically with the restenosis of greater than 6 millimeter arterial diameter. And lastly, the biggest thing that we want to do is just overall prevention of renal artery stenosis. So one being smoking cessation. Smoking cessation, or smoking in general, puts you at a huge predisposition to developing renal artery stenosis just because of the plaque buildup that smoking can cause. So smoking cessation is a major one. Maintaining a healthy BMI and a healthy diet kind of go hand in hand. You really want to make sure you're consuming the right foods and having an overall balanced diet so that cholesterol does not build up in the renal arteries, and making sure you're taking care of your body, as well as making sure you're visiting clinics to check your blood pressure and just overall health control. And then lastly, exercise. There was one physician that kind of complimented this study and was saying that whenever you exercise, all you need is about 30 minutes of movement a day minimum, just to get your body moving and assuring that you're having an overall less sedentary lifestyle. And these are my references. Can I open the floor for any questions?
Awesome. Thank you so much, student Dr. Carter. As you just said, if anyone has any questions, feel free to either raise your hand with the Zoom function, or if you can't talk, you can type it in the chat and I will read it out loud. Student Dr. Bahaman? I'm not sure if I said that right.
Yeah, no, that was good pronunciation. Sorry if it's a little loud at Joplin's cafeteria. I think, one of the interesting findings that the study had was the stenosis rates, specifically the inverse correlation of it due to the size prior to revascularization. So I'm not too well versed on other chlorotic diseases, but is that seen in other stenting procedures for that to revascularize like that, or like cardiac arteries or such?
Are you referencing the rates of the size of the arterial diameter at the beginning, and then the inverse relationship between the two?
Yeah, stenosis coming back.
I haven't done much research, and I would assume the next step that I would follow up with would be coronary arteries, because that's where a lot of stents are used as well. I would assume the same would be applicable there as well, just because whenever you think of the renal arteries, if they're already severely stenosed at the time of revascularization, the rate of restenosis you would think would probably be more probable. But if the renal artery is about approximately the size as it was normally before the atherosclerotic plaque deposition, then you have a less likelihood of restenosis, if that makes sense. So you would assume the same for coronary arteries. If there is less atherosclerotic deposition and less narrowing, then you would assume that restenosis would be less likely.
Dr. Wolf?
Yeah, I'm curious. I covered this a little bit in the hypertension lecture. I don't know if you remember anything that I had there related to that.
Yes, I did.
But so I was kind of curious. I mean, years ago, we used to teach that when there was renal artery stenosis, that was kind of one of those things where you could automatically go in and fix it just by fixing that lesion. And then, as I showed in my notes, as time progressed, the idea was, well, you can't heal a kidney that's already shot. I mean, if the kidney's function is shot, you're not going to help. And then the other problem that has happened is when you're losing kidney function and the old law of Laplace, so that's why the angiotensin receptor blockers or ACE inhibitors are helpful for preserving kidney function, because by dilating the efferent arteriole, you reduce the glomerular hypertension, so that when you dilate that renal artery like that, you don't blow the kidney up, because the remaining glomeruli are going to hypertrophy, and as they hypertrophy, it takes less and less pressure to cause them to pop because of that law of Laplace thing. So this was kind of interesting to me. Among the things that I was curious that I didn't hear you mention was the difference between unilateral versus bilateral revascularization. So from an experimental model standpoint, that's one kidney, one clip, which would be like bilateral renal artery stenosis, where the blood pressure theoretically went up to reach a point where the post lesion pressure is fairly close to normal. And the two kidney one clip, where you got the blood pressure going up on one side because of the renin-angiotensin system, but the other kidney now undergoing a pressure diuresis and natriuresis because the pressure's gone up. So I was curious if there was distinctions there. Sorry for the long ramble.
No, it's okay. There were a few distinctions, but it was talking about how there's so many different contributing factors for a bilateral versus unilateral renal artery stenosis of atherosclerotic deposition. So I just kind of kept it more surface level of assuming that it was just going to be unilateral as opposed to differentiating between the two. If that was a sufficient answer for you.
Yeah, no, fine.
Oh, okay.
It seemed like you were focusing more on unilateral, and
yes.
And I'm thinking, well, if it's atherosclerosis, I didn't think it would be choosing a side necessarily.
Yeah, I just stuck with you. The supporting documents that this article used had so many different unilateral versus bilateral, so I just went with unilateral and stuck with that. But yes, you are right. That would be a good clarification moving forward. Any other questions?
Well, if not, or if someone's typing in the chat really quick, I just wanted to say thank you so much again, student Dr. Carter. That was a great presentation. You did a really good job walking through all your visual aids and presenting the information very clearly. So thank you so much again. And thank you everyone for being here today.
Thank you guys. Take care.